This is Michael Altos recording part 3 of Transfusion Medicine from Barish chapter 16. Now we're going to talk about the risks and various adverse effects that can occur during a transfusion. The first is the question of infectious risks. For many years, this was the thing we talked to patients about the most, especially during the years of HIV scare. And in fact, transmission of infectious diseases probably has more to do with the prevalence of the disease in the world right now. So diseases that are more prevalent are more likely to occur in the blood supply. But in fact, these diseases are pretty rare. So the risk of HIV transmission is less than 1 in a million. For Hep C, it's about 1 in 1.7 million. And we are helped by the fact that the window of transmission is very small. This means to say there is a window between which a patient could have viral load in their blood, making them communicable, but the virus won't yet be detected by the standard PCR techniques that are used to screen our blood supply. And so fortunately, these windows are very small for HIV and hepatitis C. Compare this with hepatitis B or HTLV. These have a very long window between when the blood could be infected and when it can be detected by PCR. We have here statistics also for CMV, as well as bacterial infections, most commonly with platelets and also with packed red blood cells. And remember that not just viruses and bacteria can be transmitted, but less common viruses like West Nile virus, Epstein-Barr virus, prion diseases, Lyme diseases, parasites like malaria and syphilis, all can be transmitted by blood transfusion. Now let's talk about some transfusion reactions. The one that people think about most when they think about a reaction is an acute hemolytic transfusion reaction. This is the reaction that occurs when a patient gets the wrong blood type. It's actually pretty rare. It happens about 1 in 80,000 transfusions. The signs and symptoms are pretty well known: nausea, vomiting, fever, chills, diarrhea, shivers, hypotension, tachycardia, flushing, shortness of breath, chest pain, back pain. People get this sense of impending doom, which is very specific. People can begin to bleed and go into DIC, and they can start to break down hemoglobin and have hemoglobin in their urine. Bear in mind that most of these signs and symptoms will be masked under general anesthesia. And so diagnosing an acute hemolytic transfusion reaction during anesthesia may be challenging. As I said, this occurs when the donor unit is incompatible with the recipient, and as a result, the donor red blood cells are hemolyzed by the recipient's antibodies. This can lead to DIC, acute renal failure, and about 2% of patients who get the wrong blood type will die. This could occur with incompatible FFP as well. It's a reverse reaction. Now the recipient's red blood cells are being hemolyzed by the donor's FFP. And these are some of the various common antibodies that exist on red cells that can be the underlying cause of an acute hemolytic transfusion reaction. The most common cause of a hemolytic transfusion reaction is a clerical error or a problem with proper patient identification. That is, this is an error of process, not of product. And so it's really a human factors question. What exactly is going on here? Well, the recipient has antibodies, specifically IgM antibodies, and I would remember that because that's something I would see on a board exam. These IgM antibodies will bind to antibodies on the donor's red blood cells, activate complement, and start hemolyzing those cells. So there's release of various vasoactive substances, including bradykinin, which leads to fever and hypotension, histamine, and that causes the bronchospasm, the flushing, the itching, the dyspnea. And finally, the hemolysis releases free hemoglobin, which is a very damaging substance. It can damage the renal tubules and deposit antibody-antigen complexes and thrombi into the renal vasculature, leading to oliguria and renal failure. What is the treatment for an acute hemolytic transfusion reaction? First of all, the transfusion should be stopped immediately and the blood bank should be notified. The most important things to do are to treat blood pressure with volume impressors, preserve urine output with fluid diuretics and bicarbonate in order to clean out those kidneys, and prevent DIC, which I'm not really sure how you're supposed to do, although it is one of the recommendations. But obviously, maintaining fibrinogen levels, proper levels of platelets and FFP, and supporting the circulation. Labs should be followed, all of the labs listed below. And this should be confirmed with a direct Coombs test. Let's check again and see what that Coombs test is. Before we talked about the indirect Coombs test, and that was what we used to type and screen blood. Remember, in the indirect test, we took some standardized red blood cells that had a known antigen, and we mixed them with the patient's antibodies, with the patient's serum. And then we figured if the antibodies stuck to the donor cells, then when we add some anti-human immunoglobulins, which are antibodies, they would bind to the patient's antibodies, which were bound to the red cells, and form this agglutination. A direct Coombs test really just skips one step because the incubation is happening directly inside the patient. So a donor's red cells have been put into a patient's serum, and we suspect that perhaps the patient's antibodies have bound to some donor cells. So we take a sample of this patient's blood, we add some of these Coombs reagent, which again are the anti-human antibodies, and we look for agglutination. And if we see it, we know that there's some sort of an antibody-antigen thing going on inside the patient as a result of receiving these donor blood cells. So we confirm an acute hemolytic transfusion reaction with a direct Coombs test. Now there is another kind of hemolytic transfusion reaction, which would be a delayed hemolytic transfusion reaction. And instead of being caused by the IgM antibodies, the delayed reaction is caused by IgG antibodies. These are usually minor red cell antigens, not the major antigens, and they aren't often detected during a cross-match because they have such a low serum level. Usually what happens is the patient had a prior exposure to this antigen from a prior transfusion or from pregnancy, and now they've developed antibodies, and the second time around they have a more clinically noticeable response. So instead of an acute reaction, this is a delayed reaction. And so they start lysing red blood cells upon re-exposure. This occurs extravascularly, usually in the liver or the spleen, and as you can see, it's much more common. But it occurs 3 to 10 days after transfusion. So this might happen long after the operating room or even after the patient has been discharged home. Patients may present with a low-grade fever, some jaundice due to the red blood cell lysis, maybe some hematuria or a rash, and of course a decreasing hemoglobin as they have hemolysis. This also will show a positive direct Coombs test, just like the acute hemolytic transfusion reaction. These patients at this point only need supportive care and hydration, and usually the reaction is self-limited. Alloimmunization refers to patients creating or inducing an immune response after they become exposed to the antigens on donor cells. And every time a patient gets a transfusion, they have some risk, a 2% risk, of becoming alloimmunized to a new antigen. And as I just said, once a patient is alloimmunized, they can have a subsequent delayed hemolytic transfusion reaction. One very specific type of alloimmunization is the post-transfusion purpura, which is very rare. These people develop purpura 5 to 10 days after transfusion, and this is due to alloantibodies to human platelet antigens. We almost always see this in women who were previously pregnant, and actually they will destroy not just certain platelets, but all human platelets. So this is associated, as you can imagine, with very high mortality, and the treatment is with IVIG or plasmapheresis to attenuate this autoimmune response, or this alloimmune response. One of the most common reactions to a blood transfusion is a minor allergic reaction. This is itching, swelling, and rash and can be treated with Benadryl. And if patients develop this frequently, they can be pretreated with Benadryl and steroids. Saline-washed red cells should have a lower incidence of precipitating a minor allergic reaction. By removing the excess plasma, we can prevent this allergic reaction, although the washing isn't enough, as we said before, to prevent graft versus host disease or HLA alloimmunization. Obviously, FFP and platelets cannot really easily be washed. Patients can have an anaphylactic reaction to a transfusion. This is pretty rare, as you can see. And actually, this is usually not an IgE-mediated reaction. So in the old lingo, this would be an anaphylactoid reaction. Nowadays, we would just call it a non-immune anaphylactic reaction. And the symptoms would be dyspnea, angioedema, bronchospasm, hypotension, all of the classic signs of anaphylaxis. It's important to know that patients with hereditary IgA deficiency are at increased risk for this anaphylactic reaction. That's something you would see on a board exam. And we avoid it by using washed red cells, or if you know that your donor red cells came from an IgA deficient donor. Patients can have non-hemolytic transfusion reactions, and one of the most common of all the reactions is a febrile non-hemolytic transfusion reaction. This and the minor allergic reaction are the two things that the nurses are really watching for that is actually likely to occur during a typical transfusion. In these reactions, the recipient's antibodies are against HLA proteins on donor white cells. And once this reaction occurs inside the recipient, they'll have fevers and chills, nausea, some respiratory distress and anxiety. They may have myalgias and cough. And this usually happens within about 4 hours of transfusion. We can treat it with acetaminophen, and you may wonder, how can we make sure that this isn't a hemolytic transfusion reaction? Well, the easiest way would be by looking at the Coombs test. And if the Coombs test is positive, it's a hemolytic transfusion reaction. If the test is negative, then we're thinking about a non-hemolytic transfusion reaction. Now that we use leukocyte-reduced red cells, we're much less likely to have this problem because we won't be receiving donor leukocytes into the recipient. One topic that's very hot in the literature right now, and we see frequently on board exams, is TRALI, transfusion-related acute lung injury. The incidence is not that high, 1 in about 1 to 5,000, and the definition is non-cardiogenic pulmonary edema with acute bilateral infiltrates and hypoxia. So this means we want to see a PF ratio of less than 300 or a SAT of less than 90 on room air. There has to be no evidence of volume overload, either by left atrial pressures or pulmonary wedge pressure. And this most commonly occurs with platelets and FFP, although it can occur with red cells as well. This is in bold and underlined because I see it on exams all the time. TRALI is the leading cause of transfusion-related mortality. What's the mechanism? We think that the mechanism is that neutrophils become activated and are sequestered in the lung. What this means is the donor product has antibodies, and they complex with white blood cell antigens in the recipient. This raises questions about who these donors are, because it seems that these donors got the antibodies by some sort of alloimmunization process. And this is part of the basis for avoiding female donors, and certainly female donors who may have been pregnant in the past, because as females become pregnant, they're exposed to additional antigens, and therefore they develop more and more antibodies. So once these activated neutrophils are bound up by donor antibodies, they sequester in the lung and cause the lung injury. Some say this is a two-hit model, where you have to have a pre-existing inflammatory state of some kind, which many of our transfusion patients are already in due to trauma, surgery, or other injury. And now those neutrophils get activated by reactive lipids in the stored blood. So it's not just the antibodies, but it's actually inflammatory substances in the stored blood, which activates these neutrophils. So we see two different hypotheses for what is it that causes TRALI. Usually this occurs within 6 hours of transfusion, and patients have dyspnea, fever, chills, and pulmonary edema. The treatment is really only supportive, so ventilator and fluid management. This can be prevented with leukocyte reduction, but of course that works best for red blood cells, and avoiding female donors, especially those who have been pregnant in the past. Graft versus host disease is a very rare complication. This happens when the donor's plasma has a response against the recipient's blood cells. So this is almost like a hemolytic transfusion reaction in reverse. Usually patients who are immunocompromised are at highest risk for this to happen. So patients who have had stem cell or bone marrow transplants, patients with B-cell malignancies, maybe patients who have solid organ transplants. We also see this a lot with consanguineous donors. So if people have directed donation from family members, they may be at increased risk for graft versus host disease. Symptoms occur within 4 to 21 days. They start as a fever and rash and then progress to diarrhea, liver dysfunction, and then to pancytopenia. This is very highly fatal. We prevent graft versus host disease by irradiating the products in order to inactivate the donor lymphocytes. So this should be done especially in patients who are at the highest risk of graft versus host disease. Finally, a few things that we see frequently. One of them is transfusion-related immunomodulation. This occurs really in 100% of patients. The idea is that transfusion of blood products will decrease the recipient's immune response and increase pro-inflammatory mechanisms. What causes this? It could be due to the transfused white blood cells or other mediators which attenuate the recipient's immune response. It may be red blood cells in the microvasculature, and there's another sort of a two-insult theory, which says the patient's already ill, and that's the first insult, and then on top of that, you give them this stored blood, which may have some sort of pro-inflammatory mediators in it, or something else that exacerbates the problem. Now, this was first noticed because patients who got blood transfusions actually had decreased rates of transplant rejection. Their Crohn's disease got better, and spontaneous abortions were less common. And that was when it was appreciated that blood transfusions decreased the immune response. The flip side is that patients had increased mortality, especially when they have malignancies or infections, and we saw increased progression of HIV/AIDS, also consistent with a decreased immune response. This is probably one of the reasons why we always want to avoid transfusion in patients who have malignancy and infection. Transfusion-induced inflammatory response sort of goes hand in hand with what we just discussed. The idea that bioactive substances accumulate in the blood product during storage. As we said before, it seems like older red blood cells may correlate with more severe multi-organ failure and mortality in ICU patients. And there are those who believe that the sickest patients should perhaps get the blood with the shortest shelf life, with the newest blood. Now, moving on to one final component of adverse reactions, we're going to talk about massive transfusion. There are many bad things that occur to patients once they get multiple transfusions of blood products. They can become hypothermic, which leads to coagulopathy, dysrhythmias, acidosis, shivering, which increases oxygen demand. Patients can easily become volume overloaded, especially if they're suffering from a renal injury. Patients will easily develop a dilutional coagulopathy, and factors like fibrinogen, factors 2, 5, and 8, and platelets can quickly become depleted if they aren't transfused with a proper ratio of products. A decreased level of 2,3 DPG, as we discussed, will shift the oxygen hemoglobin curve to the left, resulting in less offloading of oxygen to tissues. As patients become acidotic, whether it's due to lactic acidosis or excess CO2 or even citrate. There's a lot of free potassium that's released in stored blood, which can make patients hyperkalemic. Patients can develop citrate intoxication due to the citrate in all of the products, and this can cause hypocalcemia. This is most common with FFP, although it occurs certainly with all different kinds of blood products. Patients can develop iron overload, and we worry about microaggregates polluting the microvasculature. So all blood should be given through a standard filter, which is a 170 micron filter, and this only pulls out large aggregates. A micropore filter could be used for red cells and FFP, but benefit has only been shown in the cardiopulmonary bypass circuit. Otherwise, we don't usually use a micropore filter for blood products. What diluent should you use in your blood tubing? Well, we always teach you to use normal saline. There is a concern that the calcium in LR could bind up the citrate that's been used to prevent coagulation, and then the blood will coagulate in the blood tubing. I would say that the risk of this is pretty close to zero, unless you are in the habit of actually diluting your blood with crystalloid, in which case a 2-to-1 ratio of packed cells to LR is still fine, and a 1-to-1 ratio is probably getting a little risky. But unless you're actually pouring LR into your unit of blood, you should be fine. Take a few moments to consider if you have any questions. You can bring them to class or email them to me, jot them down, and look them up yourself. And we'll stop here. Thanks for your attention, and we'll see you in class.